Hi everyone, my name is Rachel Moses and you are listening to the ACPRC Pulmonary Rehabilitation Podcast Part 2. And I'm delighted to be joined by the second panel tonight who are going to discuss some of the challenges and opportunities in virtually and digitally performing group pulmonary rehabilitation for our patients. So I'm just going to ask the panel to introduce themselves. I'm going to start with Emma.
Hi, I'm Emma Chaplin. I'm a senior pulmonary rehab physiotherapist working at the Glenfield Hospital in the University Hospitals of Leicester.
Thanks, Emma. Fran?
Hi, I'm Fran Chambers. I am also a specialist physiotherapist in pulmonary rehab and I work up in Newcastle upon Tyne hospitals.
Thank you. Nina?
Hi, I'm Nina Garnavas. I'm the Programme Manager for the Pulmonary Rehabilitation Accreditation Programme at the Royal College of Physicians, and I also work closely with the audit team as well.
Thank you. And Karen?
Hi, I'm Karen Ingram. I'm a specialist physio in pulmonary rehab based at Harefield Hospital.
Fabulous. So the reason we're doing the second part of this pulmonary rehabilitation podcast is because the first podcast slightly went off track a little bit. So the primary idea was to discuss innovations and how we can deliver group pulmonary rehabilitation, because lots of services we use in digital technology and online platforms to deliver one-to-one exercise and assessments and advice. But actually the biggest challenge we face now in this COVID time is to produce the traditional pulmonary rehabilitation model, which we know that's very evidence-based and we know that it's very effective. So we felt after the first podcast, we achieved many things in terms of understanding the different types of exercise rehab that are being delivered. But really what a lot of people wanted was to understand some of the challenges other people were facing in terms of digital group PR and also how people were physically doing this, how they were achieving this. So I'm just going to recap on some of the challenges of simply just lifting up a group pulmonary rehabilitation model and using an online platform. And Fran, if I could come to you first for that question.
Yeah, sure. So when we rang some of our patients to screen them, we found one of the main challenges was major access. Access to the internet, strength of the signal, and also whether they're able to manage the technology. Some patients have family members with tablets or iPhones, but they don't have access to it all the time. As our patients are also shielding, they don't have access to this at the moment as well. Those that do have access are really unsure and have said, oh, well, if you come and show me how to use it, then I might have a go, but then I might forget as well. So those are the sort of digital challenges. Those that have been to pulmonary rehab before want patient preference is to come to the groups again, so they want face-to-face. And they sort of, the big power, the big draw of pulmonary rehab for me is the social side of it, which you won't get with a digital platform. I think we as a trust up here are exploring different platforms to use, and I think we've chosen Attend Anywhere, which we can have a maximum of 5 patients on at a time, which is also smaller than the groups that you would potentially look after. So those are the major challenges that I can think of at the moment.
Has anyone else got any different or similar experiences in their challenges?
I think even actually agreeing on platforms across various trusts, a lot of different information governance departments are favouring some platforms over others, you know, and saying that there's issues with the safety of data and things and patient confidentiality. So I think actually even establishing a common platform is quite a challenge as well.
Yeah, I think some of the challenges we talked about in the other podcast, and certainly some of the questions we keep being asked on behalf of the ACPRC and some of the respiratory leaders is around kind of patient preference, like you just alluded to there, Fran, in terms of it being a group-based activity. It's the motivation, it's the personal touch, it's the fact that the pulmonary rehabilitation evidence is based on the model that we're trying to deliver, which will be very different in a digital framework. But I think the strong feeling is doing nothing for much longer is also not an option. And while face-to-face might be a potential, there's still many risks associated with that, including transportation, bringing people onto a hospital site. And, you know, we don't know if this is over yet, so second surge definitely may happen. And the reality is we need to develop a model that could future-proof for the next months and months down the line. So, Karen, if I can come to you, because I know that you, slight disclaimer, we work together at the moment. Congratulations on the accreditation again.
Thank you. Yes.
So you've been looking into the risk management side of things, haven't you, and the information governance side of it, and you've produced some great like standard operating procedures and some risk assessment tools. Do you want to tell everyone a little bit about that?
Yeah, well, our main concern was actually with assessing people virtually. So before they even get onto their program, because for pulmonary rehab, to exercise someone to a moderate to high intensity, if you've not done an assessment first, really concerned us. So the assessment side is one of the biggest things that we wanted to tackle. And yes, using video, you can do some field tests. We're particularly erring towards the 1 minute sit to stand, which I know a lot of people are. And you can do some falls assessments, but just the challenges of actually even getting people's observations, their SATs, their heart rate, their blood pressures. So we were just trying to establish pathways for that. Do we drop off the equipment first? Do we post it? Do we, you know, how we go about that? And then how do we screen? So for all our patients, we wanted to kind of feel happy that medically we had screened them safely through a tool, and there are some out there, the PAR-Q, the Easy tool. We had screened them for falls risk. We'd also screened for the practical side of things, so that patients wouldn't be on their own when they were having an assessment. There would be an able-bodied person there when you're doing it. And some of the more practical issues of having a chair up against the wall nearby, and how they might position their device for any video assessment as well. And then lastly, we've also looked into, I don't know whether to call it a disclaimer or a waiver, so that patients actually can say they understand the risks, they've been informed of what we're doing and what the risks might be, and that they are happy to kind of proceed. So those are sort of some of the factors that we've kind of introduced into our new pathways to try and ensure that we can do a good enough assessment, but keep patients safe whilst we're doing it.
Yeah, I think, you know, from a manager point of view, they're the really important points that, you know, the managers want to know. So how have we made sure that the right patients are getting selected for a digital group program? How have we made sure it's as safe as possible? So things like you said, having an able-bodied person in the house with a working telephone and an emergency plan, so they know what to do. Because otherwise, if someone becomes unwell during the class, you could, you know, that could be distressing for the other people to be physically witnessing it at the same time, which can happen in a class format, can't it, as well? And then the third thing is what is the worst case scenario, and how have you prepared for that? What happens if there's an adverse event? So I think the, you know, selection of patients, the risk management, and then the safety is the three things that we want to know are being looked at, and then have been mitigated and or assessed and or documented. And I believe you have those documents now produced, don't you?
Yeah, it's taken a while, but yeah, I think we've got there.
I'm sure you'd be happy to share them as well, wouldn't you, Karen?
Yes, certainly. If anyone wants to know our thoughts, then yeah, absolutely.
Nina, can I come to you, please?
Yeah, I was going to say, actually, all of those things from an accreditation standpoint are really, really important, because what we're hearing time and time again is actually there's a lot of providers that don't feel very confident with those things that you've just identified. So they don't feel confident in risk assessing, they don't feel confident that they're able to support the patients, you know, virtually. So we're developing a kind of checklist of good practice. So actually, Karen, if we could reach out to you as our first accredited site and make sure that we've actually covered all of those things, I think that would really go, you know, a little while to support people to feel a bit more confident with the work that they're doing over the next few months.
Yeah, absolutely. Yeah.
Absolutely.
And I think as well, Oh, yeah, sorry. No, I was just going to say, from a patient point of view, for them to embrace a new kind of pulmonary rehab when they are maybe more familiar with the face-to-face, I think we have to be quite clear and quite confident in our pathway and in our processes and in our risk assessments, so that we can instill confidence in the patients, and hopefully they will then come on board with this new virtual pathway.
Yeah, so one of the things that we're hoping to do is, once we've kind of consulted with a few different people, is then hopefully work with the BLF to get that patient perspective and actually see what they feel is really important on the checklist, and whether actually they've experienced that. So whether, you know, the BLF patient panel are actually still engaged in PR, and whether they've had to go through the various things that people are doing across the country. I think that will be really interesting from the patient perspective.
Definitely. And just if anyone does have any similar documents to Karen's just mentioned, it would be really helpful if they could pass those on to the ACPRC, and then Nina, that could be the link for you guys, because it's sometimes we see in these situations many people reinventing the wheel, so we're more than happy to share things that are already out there. This is the whole reason for these podcast series. Emma, can I come to you with any further comments on that, please?
Yeah, I was just going to say, from our trust's point of view, what we're hoping to try and do, especially around the assessment side of things, was we were hoping to do part of it as a telephone consultation, but then hopefully trying to get the patients in to at least do the exercise capacity testing with them. So at least you have some face-to-face with the patient, and obviously you can then do all your baseline measurements with them, you know, BP, heart rate, SAT, that sort of thing. So it might give clinicians a little bit more confidence then, when you are then going to tell them they're going to be doing a program at home, that you've actually seen the patient face to face and know that they're going to be hopefully okay at home. So we're going to try and do a bit of both really, and mix it up.
Brilliant. I think, yeah, that's super helpful. So we've talked about the risks and mitigating the risks and making sure the right people are in the virtual pulmonary rehabilitation program. Emma, I'm going to come back to you about how we'll actually make this happen. I mean, me in my head, I have people with like tablets or laptops balanced on their coffee room tables, like generally not kind of discriminating against an older population here, just thinking of the older people that I know with COPD, and how is this going to work?
It is really challenging, isn't it? Because I think this group is more difficult because of their technology knowledge, essentially. And like Karen was saying earlier, you know, Fran was saying that, you know, some patients rely on family and friends to set them up, and might have only set them up on email or something, you know, on a tablet, so they can access pictures or just keep in touch. But to actually get on and do a group session with other people, I'm sure will be quite daunting for a lot of them. But I think as long as we can try and keep the groups fairly small, because the other thing is, you know, having the healthcare professional, it may be that you need a couple of you there so that you're able to keep an eye, because that's going to be a challenge in itself if you're getting patients to exercise in a group on a screen, and you're trying to keep an eye on everyone to make sure that they're all okay and they're all managing the exercises. That's going to be something that's going to, you know, you're going to have to juggle, and having a few eyes on the screen, which intuitively doesn't feel right, does it, from a staffing ratio point of view? Because low numbers, you probably only, if you were in a class, would only need one or two of you, but you might need a couple more of you, because you are going to have to be looking all over the place, checking on patients to make sure that they're okay. But it's doing something, I suppose, slightly different, in that getting them to do what we would do in our traditional program, which is walking and strength exercises. You're not going to be able to ask patients to go off and do a walk and come back to you like you would in a class. So it might be thinking of doing it maybe in a circuit-based type session, you know, where you can keep people in one place essentially and do the different exercises. That's one thing we've thought about doing. I think you're right, as Fran said earlier, you know, the social side of things with patients, they want that contact, don't they, with other patients. So even if we trial doing the education sessions so that they can all sit, get on and chat and listen to the talks. I think they'll be fairly straightforward to do. It's going to be the exercise component that's going to be the tricky part, especially if you've done an exercise capacity test that you're going to want to hopefully see change with doing a pulmonary rehab program. You've got to have the right exercises that's going to affect that, haven't you?
Yeah, and we'll definitely come on to that, and Nina's going to touch on that in a moment and how we do that. Now, Karen, I just want to come back to you at that point, because you've actually trialled a couple of classes, haven't you, to work out how this looks in theory, about having essentially, we're on Zoom now, so essentially having 4 or 5 people all in different rooms in their own houses, or in their garden, and presumably with a chair or something like that. How has that actually looked in practice?
Exactly like Emma was saying, it's having extra pairs of eyes. So far, we've only trialled it with patients that have previously done rehab or who've already tried the exercises. So they're already a step ahead of our new patients, in the sense that hopefully we've already taught them, or they've already know some of the exercise techniques and things. And actually, to be honest, to start with, it's a massive amount of education in teaching them how to monitor their breathlessness and use the Borg scales and the RPE scales, and actually trying to help them self-manage their exercise, but with your supervision. So it's a very different style class to what we're used to running. But it's more about facilitating them doing their own exercise, and as Emma was saying, just trying to have, to start with anyway, those extra pair of eyes, and try and keep the group small so that you can actually monitor everyone as best you can.
Thank you. Now, Nina, I was going to come to you with some of the comments around audit, but do you want to comment on any of that, what Emma's just mentioned?
Yeah, well, I just wanted to mention a couple of things that are happening nationally in terms of actually the practicalities around how we do this going forward. And I'm sure that people will know that some stuff is going on, but I'm not sure they'll know all of it. So one thing that's happening nationally is the NHS England are working with Sally Singh and a number of others to develop some online guidance for post-COVID patients and rehabilitation. So that's something that's obviously very, very topical right now. So I think that piece of work has been expedited, so hopefully we'll be able to see something coming out of that quite soon. There's also a piece of research that's being done between the Royal College of Physicians and the This Institute, which is in its early stages at the moment. They're doing some data collection and some literature searching at the moment, but that's looking at how to provide virtual care for people with COPD. So PR won't be the only thing that it's looking at, but obviously as one of the key interventions for people with COPD, it will cover that. So that'll be really interesting to see what's coming out of that. And again, because it's something that we need to know very soon, hopefully we'll get some of that data and some of that advice quite soon from that. So that's quite exciting national pieces of work that are happening.
Definitely, and they've kind of been happening from day dot, haven't they? I know Sally and the team are really quick off the mark in the organisations to start looking at that as a priority. So, yeah, definitely watch this space kind of stuff.
Yeah.
So audit. What's happening with audit? Do you want to give a rundown?
Absolutely. So as you probably already know, we've got the interim report coming out imminently, which is very exciting. And then we'll have the fuller report with the organisational data as well coming out sort of November-ish time. In terms of data collection, I think as a team, we have been communicating with services saying, we do really understand that it's a very difficult time. Data input probably isn't the top of your priorities, but actually we are in a really crucial time for data collection, because we could start to create some of the evidence base around, virtual interventions and the kind of patients that respond positively or don't. So we have said to services, if you possibly can, do continue to input data into the database. It is open, the team is still there to support you. And actually, when we developed the data set in, where are we, March 2019, we did future-proof ourselves a little bit. So we did put some questions around home-based PR, about the kinds of interactions that you were having with patients. So that already all exists. So you can already enter most of the data. We've also added a new drop-down option for the walk tests, where you can say that patients haven't been able to do it because we're during kind of the COVID period. So that means we'll be able to distinguish some of the data. And also, those of you who have read the technical manual, which I know you all have, will know that you are able to add your own custom fields. So actually, for local reporting and local data analysis, if you want to say, okay, this patient is having this intervention, that patient's having that intervention, this is the data that we're collecting for them, you are able to put that in and distinguish it. It's not, it's not foolproof, but it's definitely very useful. We just obviously need the data being put in.
And what about accreditation?
So accreditation, again, the team is here to support everybody. So currently, the way that accreditation works is the first part of the pathway is about self-assessment. So services get access to the web tool, get access to the full standards, and they go through a period with our support, kind of going through the standards, self-assessing and uploading evidence for those standards. The next section of the pathway is about peer evaluation. So we send out an assessment team. We do a remote assessment for the first part, and then we come on site, meet the team, meet some patients, have a look at their area, environment, etc. So obviously what has been on hold during this period has been the site assessment, because we haven't been able to come out on site. What we have said now is that we are able to restart site assessments from September. Which means that services are able to submit their self-assessments from July. So if you're ready and you're rearing to go, please get in touch with us. We can support you. You can submit your self-assessment and we can start that assessment process. Come September, we'll be guided by what's going on then. So it depends. Different trusts will need different things from us as an assessment team. We will still have lay assessor engagements, so we will still very much be involving the patients within that assessment, but we'll be doing it remotely or flexibly depending on what's going on at the time. So one of the things that we get asked about a lot is, well, if I'm doing PR virtually, how am I going to get any evidence? Actually, if you have a look at the evidence, it spans lots of different areas, not just clinical practice. So most of the things that we hold dear about our services, the staff, the leadership, the risk assessments, all of that stuff actually will still be in place whether you're seeing patients in-house or not. So what we say is, do have a look at the standards. If you can, give it a go, crack on, we're here to support you. And what we're saying is that if you are ready to be assessed and you're still not seeing patients, we will be proportionate and flexible. So if you can evidence that when we were in the normal world, you were meeting those clinical standards, and actually you've got a really robust plan post-COVID, and you've got a really robust, innovative way of supporting patients right now, we'll take that all into consideration.
Thank you, that's super helpful. Now, just to swing ball it a bit, I'm coming over to you, Fran. So again, just with my kind of manager head on. So I've managed pulmonary rehabilitation services in and out for a long time, and they were always like one of the Marmite rotations. You know, people used to go and they used to love pulmonary rehab in terms of the physios, and some people used to go and just think, my goodness, no, this isn't for me. So in this digital world, is there a risk that patients are going to feel the same? Do you think you're going to have a patient turn up once to a session and think, goodness no, the dropout rate's going to be high, you can't engage with them? I know there's some managers out there thinking, this is my pulmonary rehab teams are spending a lot of time trying to make this happen and it's still not happened. So what's your kind of take on that?
I think we need to have as many options as possible. You're right, not one size fits all by any means. The positive side of this is that I think we could potentially reach a lot of patients that we couldn't reach with the traditional class program. Those patients that work, so sort of the MRCD2s almost, and those patients that are housebound. So the MRCD5s, the ones that are so breathless and actually need really specialist help, but can't access it because they could never have enough strength to make it to the hospital program. So from a positive side, I think actually we might be able to reach a lot more patients than we could previously. But as I said, one size doesn't fit all. So I think digital, brilliant. If they're up for it and they want to have a go, we'll go with that. Equally, we would like to offer a one-off home visit for our patients, to meet them, give them a face-to-face, check their environment, check their suitability for doing the exercises, see what equipment we can or cannot leave with them, and go from there, and try and make it as adaptable and tailored as possible. Yeah, that's what I think we should do.
No, I love that answer. Thanks, Fran. So Emma, kind of coming to you a little bit next in terms of the delivery of the digital pulmonary rehab. Seems, it's complex. It hasn't been straightforward in how we do this. Why is it important? Why is it important we continue to do this? I mean, that might seem like a really simple question, but what is the real value here for these patients in getting this right and mobilising our pulmonary rehabilitation services?
Sorry, I was muted. I think it's important because these patients can't be left to do nothing. That, I think that's the worry, isn't it? That if they stay at home, and I know it can't be helped with some of it because it's of the shielding, etc. But if they're at home and they're not doing anything, physical activity goes down, and that's all intertwined, isn't it, with readmissions and mortality rates. So they need to be doing something. They can become very deconditioned just sitting at home doing nothing. So like Fran was saying, something is better than nothing. So if we can get them engaged into doing something, and also it might surprise us that actually quite a few of the patients can access the digital platforms and are happy to do digital at home because of things like, if we were to offer evening classes or Saturday classes, I don't think we would have a huge uptake with that. But actually this might suit patients in that you could do it and they can do it at home and follow it, and you could pick a time that would maybe suit those that are working until in the afternoons and things like that. So it could work in our favour in that it's a very flexible and offers more choice to patients for the pulmonary rehab.
Thank you. And Nina, just coming back to you, do you think we need to think about some different avenues of research now for pulmonary rehab? I know you've mentioned some of the work that's going on, but do you think this might change tact a little bit?
I think there's definitely a space to build on the evidence base for virtual. So as audit and accreditation providers, we are limited to the evidence base. So we can't go rogue in terms of developing standards because we think it might be good for patients. Actually, we're very tied to, we can only audit what is in the evidence and we can only accredit what's in the evidence base. So I think this definitely is a space to really promote innovation, which I think we all know from Twitter and speaking to our colleagues that a lot of different services are doing some really great and innovative things. So being able to harness that, to share it, and actually to see whether it's having a good impact on our patients is really important. And I think, yeah, definitely there's a lot of support from NHS England, and there's a lot of different appetite to have a look at what we're doing. So I think, yes, definitely we need to be having a look at building that evidence base. And I think very much what Fran said, not looking at changing the landscape of PR completely, but actually looking at how we move forward and make sure that we're having an integrated, more innovative service rather than just digital or just face-to-face.
No, definitely, and I think that's something that was covered really nicely in the first podcast as well. So I think definitely, even if there's kind of slight differences in opinions about how that's done, I think everyone's in agreement. It's a flexible tool, isn't it? But it has to be evidence-based. We'll have to use the evidence that we know is out there. So Karen,
Absolutely.
I'm going to come to you next, Karen, for kind of some final thoughts before I go around everyone. So have a think, everyone, if I've missed anything out. So Karen, we know that a lot of teams are struggling to just get going with this. And you're going live, I believe, on Monday, is that right?
Yeah.
So what advice do you have? And I'm sorry, your inbox is probably just going to be absolutely mental, or mine will be, because I'll be wanting your email. What is your advice to people out there who are just really struggling to just get going?
Yeah, it depends a little bit on your timescales of when you want to start, because certainly you've got to have the pathway mapped out, partly so you can plan, the paperwork, the risk assessments, everything that you need, but also so that you can inform the patients of what to expect and what's ahead. And then once you've got your pathways mapped out, you can then start to actually trial out the assessments, trial out the classes, trial out the platforms, so that you can then find out, how to work it, how to do it, what all the kind of problems are and how they arise. And then ultimately, it's a case of giving it a go. I think, particularly at the moment, we're in such unusual circumstances that patients understand that. And I think if you tell them that this is a new pathway, a new service, a new kind of way of doing things, I think most of them will be on board and give us a bit of grace with that, whilst we kind of iron out maybe some of the difficulties along the way. And actually, I'm hoping to actually get their feedback from it, so that we can just sort of develop things as we go. So I think don't be afraid to try it, waiting for the perfect method, because I think actually that's going to be an evolving thing. So yeah, that's probably my advice in a nutshell.
Thank you. Emma, can I come to you for any final thoughts, please? Oh.
The only thing really I finally to say is it's a great opportunity whilst we're setting up these new virtual way of, or digital way of doing things, just to try and always think ahead of what you could collect data-wise, because, it's all new, we don't know how it's going to pan out, and it's the perfect opportunity to just try and collect lots of data. I know we've sort of adapted like satisfaction questionnaires, and we're going to do some interviews with patients to find out what they've thought of what we've done so far with patients during this COVID period. But whilst we were thinking about it, we sort of jumped on it, which is great, because then you can always have that data, can't you? And you can then present it, and you always learn from it and something new. So just try not to forget about that either, because that's always very informative for services.
Absolutely, thank you. Fran, coming to you next. Any final thoughts or comments?
Yeah, I think it's quite an exciting time for pulmonary rehab. As I said earlier, I'm excited by trying to treat those patients that we couldn't previously get to. And also, I think it's really important to listen to your patients. It might be that you start off on a virtual digital platform, but actually if it's not working out for that particular patient, it's okay to say, fine, we'll have to reroute and try something else. And it might be simple paper and a pen and a few really simple exercises at home whilst they get started and build up their confidence.
Fab, thank you. And Nina, any final thoughts from you?
Yeah, I suppose I've got a couple. One in terms of clinical, very much echoing the others, that I genuinely think it's a really exciting time for PR, and taking the opportunity to involve your patients where you can in this kind of developing world. And also not assuming that patients will continue to feel the same way. So, they may have said a month ago that they didn't fancy it, but actually this situation might not be changing for a little bit. So it might be worth going back to people and seeing whether they've become a bit softer to the virtual options. And from an RCP perspective, just very much telling people that we are here to support you from both an audit data input perspective and from an accreditation perspective, and to not be afraid of accreditation. Again, we're here to kind of develop PR and make sure that we're setting high standards, so we are here to support you, you know, when you're ready to engage.
Thank you so much. That's great. And a massive thanks to the panel. I think they're going to launch this through the website and on Twitter, and I'm sure any comments will be greatly appreciated. Thanks very much, everyone.
Thank you.
Thank you.